Hi, I'm Dr. Brian Koffman, a retired family doctor and a CLL patient myself, and the Chief Medical Officer, Executive Vice President of the nonprofit CLL Society. You want to introduce yourself?
Sure. Thank you, Dr. Koffman. My name's Bill Werbel. I'm a transplant and oncology infectious disease doctor at Johns Hopkins, where I'm a physician who sees patients and a scientist who does research usually in prevention of infections in people who've had transplants or have some kind of cancer.
Dr. Werbel, as an infectious disease specialist, especially one doing the kind of work that you're doing with the immunocompromised, you've had to become almost an immunologist yourself in terms of understanding how the immune system works because you're dealing with people whose immune systems are impaired. So first, explain to me, we know one of our mantras at CLL Society is all CLL patients are immunocompromised to some greater or lesser extent. What, talk to us first generally, what does it mean to be immunocompromised? Because that's a very broad thing, and then maybe we
Right.
can focus specifically on how CLL patients are immunocompromised, and then we'll talk about some of your research on vaccines and other things.
Yeah, great. A simple yet complex question. In the ID world, infectious disease, we often refer to the net state of immunosuppression of a person, which is really very personalized, individual, and it comprises almost anything you could think about. First, like the integrity of your different body parts, like your skin or your gut, the how old somebody is, other chronic medical conditions, having diabetes or having heart disease or lung disease. And then the thing that's a little bit more bespoke, maybe, is the nature of the immunosuppression a person has, which can either be something that's you're kind of born with, a genetically associated problem with the immune system, or something that's acquired over time. And that can be from medicines that you're given for a certain condition, or the development of something like a blood cancer that lead to this sort of worsening of the net state of the immunosuppression of an individual. And so if you're talking about CLL in particular, all the first bunch of things I mentioned apply. People who are older, who have chronic medical conditions, all contribute to immunosuppression. But then the specifics for CLL are related to the bloodline, the different cell lines rather. Typically, if we're talking about the CLL itself, it has to do with the cells that make antibody, and sometimes the cells that also fight off certain infections, particularly viruses. That's sort of the nature of what CLL itself can lend to this net state of immunosuppression. Then it does get more complicated depending on the medicines that people are taking. Something like a steroid, very common things like prednisone, are diffusely immunosuppressive across all the different parts of the immune system, not just those lymphocytes, the L in one of the L's in CLL, and then other things that are really focused on getting rid of B cells or getting rid of T cells, these things that fight off viruses, like these lymphodepleting medicines like rituximab can kind of deepen the immunosuppression in one of these compartments.
And in CLL, we know that it's a cancer of the B cells, but those B cells are non-functional and it can suppress the other B cells from being functional. And I want to get to that. But we also know it seems to impair the ability of the T cells to work. And those T cells are the soldiers of the immune system. They don't seem to work. And also impairs the innate immune system. So it's not just the adaptive or it's also the innate immune system. Remind us the difference between the innate immune system and the adaptive immune system.
Sure. So, without maybe getting too technical, there's parts of the immune system that are kind of almost always active and are a little bit less specific, so to speak, for certain attackers. When we talk about, and we'll jump to it in a second, like antibodies and things, those tend to be very specific. But there are parts of our immune system, like alarm cells, sort of that can sound the alarm, that are also constantly sort of active or surveilling sites that are at risk that uh, contribute to a lot of times the kind of early and sometimes less specific immune responses to something foreign trying to attack us. And a lot of times those are cells that are not, again, these lymphocyte cells, or tend to be like macrophages and other parts of immune cells that can send off cytokine warning signals, can recruit other cells when they encounter pathogens. And those are, again, not traditionally the problem in CLL, but something like steroids, like we mentioned, will suppress the innate immune system. The adaptive immune system is one that, kind of as the name implies, takes a little time to sort of generate, and tends to be ones that are more specific to certain pathogens, infectious organisms, usually, either things that either these antibodies that are very specific to bind or neutralize pathogens, or T cells, other parts of the immune system that can identify, attack, and kill infected cells. And those, again, are typically more what we call either antigen or pathogen sort of specific, like, oh, it's a flu T cell, or it's a, COVID T cell, for example.
And it's even more than that. It's this particular strain of flu, it's this particular strain of COVID and whatnot. And this is why it's adaptive, because it's adapting to that. And that's what vaccines do, right? They work on the adaptive immune system so when the true pathogen, the true bacteria or virus or whatever it's protecting, or toxin or whatever it's protecting us against, comes along, we say, oh, we've seen that before, and those soldiers are primed and ready to go. They don't have to learn from scratch and get the innate system there to send the alarm and send the soldier. It's all ready so we can respond more quickly. You've done some research on vaccines, and this is across all immunocompromised patients. Tell us a little bit about that and what might and might not apply to CLL patients, because we're worried about our responses to the vaccines, and we've been very big on pre-exposure prophylaxis with passive immunity, but that's been very difficult with COVID, and it's not really available. It's available in some other very limited capacity for some other issues. So help us understand what's happening when we get vaccines, or in your study, what happened you found about vaccines for that general immunocompromised population.
Right. Thank you. So, we've done a lot of work, beginning mostly in the COVID pandemic, but now stretching into other important viruses, like first RSV and then soon influenza, looking at immune responses to vaccination in people who are not traditionally in these regular clinical trials. Most clinical trials are of people with relatively normal immune systems, and that's how you can kind of really assess if a vaccine is working. But we don't have as many trials in people who had stem cell transplants or blood cancers or organ transplants. So our group, fairly early in the COVID pandemic, was very invested in studying COVID-19 vaccine responses. It was obviously a very troubling time with limited information. And so we mostly have studied people with solid organ transplants, but also people with other immune conditions like autoimmune diseases, getting medicines like rituximab or mycophenolate, which is a medicine that people, or Cellcept, people take after transplant. Also some other biologics.
And people take these drugs to suppress the immune system. So autoimmune's when the body's attacking itself, and they suppress the immune system. So your rheumatoid arthritis isn't attacking your joints, but your immune system isn't also maybe defending you as well. So prednisones and the steroids are wonderful life-saving drugs if you're having a severe asthma attack or reaction to something, but they also have all these adverse events because they suppress all of immunity. And there's a whole bunch, having had a transplant myself, you go through all kinds of immunosuppression because you don't want to lose the graft that you've just been transplanted. So you have to suppress the body. And chemotherapy too is very immunosuppressive, isn't it also?
Yeah, and definitely varies by what kind it is, but the ones that people receive for things like stem cell transplants are very immunosuppressive, and it tends to take a couple of years to really get back to sort of normal status. Your point about autoimmune diseases and the sort of so I think one of the things that's important and relevant to COVID is that these medicines tend to, their purpose is to not allow you to respond or generate immunity, let's say, against either your own body or a donated organ system, either
Or a CAR T cell?
or yes, foreign cells. And so it's almost like an off-target effect, where by trying to accomplish that former principal effect of protecting your bone marrow graft or protecting your liver transplant, it will reduce the ability to respond to basically anything kind of new, so to speak, or different. And a vaccine is often that. It's something new, or in particular with COVID, it was very new. And so we were concerned that people on high doses of immunosuppression would not be able to generate immune response targeted at this new thing, because by kind of definition, the medicines people are taking are to prevent that. And it's particularly bad with COVID because it was such a new pathogen. There wasn't stored memory, so to speak, in your body that was going to get boosted by a vaccine, something very new. That's why it took 3, 4, 5 vaccine doses for people to kind of generate this adaptive immune response to something totally new in a very immunosuppressed state. So that was one of the main things that we had found, which is after 1 or 2 vaccine doses early in the pandemic, and has been well publicized, immune responses were quite poor, and people with CLL were one of these groups where it was almost a 50-50 or worse proposition to develop any antibody, period, let alone high levels of neutralizing antibody necessary to like keep the virus out.
So, is there anything in your research related to the immunocompromised in general and the CLL patients in particular that we can sort of take to the bank? Is it what I'm hearing is maybe more is better, getting repeated vaccinations, or is there issues with that? I mean, what did your studies say in terms of what our responses would be? And
Yeah.
is there any way to boost those responses? Because that's what patients are going to be interested in. Obviously, we always say to people, get your shots before you go on your treatments. You know, the sooner you get the shots, the better. Your immunity is not going to get better. These kinds of things. But any advice that you give patients?
Yeah, I think you've mentioned a couple, which is the expectation should basically be for most things that more is going to be necessary. Number of doses, usually. That was why the primary series for COVID was expanded to 3 for immunocompromised individuals as opposed to 2, because that was seen to rescue some responses, and why boosters are recommended on a more frequent or permitted on a more frequent basis and tend to be recommended more frequently as well. Like now it's every 6 months for a COVID booster. Um, I think that has shown to be the case and might be the case for newer, less studied vaccines such as RSV vaccines. And that was a recent work that we just had published in JAMA that showed that in a pretty diverse group of immunosuppressed people, mostly transplant, solid organ transplant, but some with autoimmune diseases on medicines like mycophenolate or rituximab, a single RSV vaccine dose was led to very heterogeneous immune responses as compared to
Very mixed
very
response.
mixed, as opposed to almost like universal, very good antibody responses in the average older adult, where people would boost their antibody levels about 10 times in a healthy population. It was kind of a 50-50 proposition to even reach a 4-fold increase, a 4 times increase, which is generally used as a rough metric for having responded. Additionally, when we measure this neutralizing kind of virus killing antibody in against RSV, the number of people who are achieving a relatively conservative threshold, much lower than that was seen in the healthy trials. That was only, again, about a 50-50 proposition. And so there are people on heavy immunosuppression, and there are people with CLL who would meet these criteria. You're getting rituximab, you've had a recent stem cell transplant, you're taking multiple medications like a BTK inhibitor, like these sort of ibrutinib type medicines, as well as chemotherapy,
And I
where,
would add the bispecifics that
oh,
are
for
being used
sure.
now, obinutuzumab, which is like rituximab. So all of these, and uh, and of course CAR T therapy for the people about CAR T, which gets rid of all your antibody forming cells if it's successful, because it attacks all of them, the good and the bad. So lots of reasons. But even people who don't have that have had problems just because the cancer itself suppresses the immune system. Yeah.
Right. And so I think, to me, even though it's not exactly apples to apples with the population studied, the suggestion that a single RSV vaccine dose is going to be um, all that somebody might need to create high levels of antibody seems less likely to me. It doesn't mean that one vaccine is not helpful. It doesn't mean that we shouldn't follow and respect CDC guidance. It is recommended for all people 60 and older who have a chronic medical condition like CLL. But I think what needs to be continuously reevaluated is, you know, do we need multiple doses to start? Do we need booster doses on a seasonal kind of cadence? Those are not known and I think are important and questions that require dedicated study, like was done with COVID, for example.
Any final thoughts on your vaccine research and how that would apply to CLL patients? Any takeaway messages that you want to get across to the CLL community or the immunocompromised community in general?
Yeah, I think it's a little nuanced, but important to say, like, hey, vaccination can be effective and is recommended, and we shouldn't sort of despair, maybe, that they're not going to be as robust as in the general population. There may be updates and ongoing sort of knowledge that tells us that more may be necessary for any of these studies and any of these products, rather. But we need to be maybe eyes open about the potential limitations or lack of sort of complete protection afforded by them. And then that means there are other things that we may have to do. Sort of taking non-pharmaceutical, approaches to reduce risk at times of high virus circulation, avoiding high-risk behaviors and sort of events and such. Right now, we're at basically the peak of respiratory season, so there will be circulation of many viruses that can make people with CLL sick. So being kind of smart and judicious about exposure risk, that's something we're probably going to always have to maintain. And then the last is, keeping abreast of other complementary things to vaccination, like we've discussed before in this spot, like passive immunity, whether that's these IVIG, immunoglobulin sort of add-ons to vaccination, or if available, monoclonal antibodies that do work very well when they work. So I think the companies and FDA and everybody's invested in protecting immunocompromised persons, and there's sort of this ongoing pipeline that hopefully will add to what is probably suboptimal but still important immune response to vaccines.
Dr. Werbel, this was very helpful. I learned a lot, and I'm sure the people who are listening to this learned a lot. Thank you so much for your time, and thank you for the research you're doing at Johns Hopkins.
No problem. Thanks for having me back, and hope everyone has a great holiday and winter season.